truth and justice reign, in peace over to all, and this becomes sustain. To our children, abandon without stain. O God of all creation, grant this our request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed.
Thank you. One more time, very especially welcome you all to Nigerian Telehealth Conference 2025. Today we are gathered to celebrate and identify key factors and enablers towards the implementation of telemedicine and telehealth guidelines in the Nigerian healthcare system towards the achievement of universal health coverage. With our theme, Scaling Telehealth for Universal Health Coverage in Nigeria, Pathway to Sustainability, we will be discussing policy and regulations, financing and sustainability, delivery and access to telehealth. I'd like to especially invite you all to this very amazing conference. We are here doing the right thing, having the right conversations, and getting ready to make sure that the future of healthcare is not coming, but the future of healthcare is now. My name is Chooks the General. I'm going to be your compere for today's conference, and I'm sure that you'll have a very wonderful time. Let me especially welcome all government leaders, health professionals, development partners, private sector individuals, and civil society members who are here to discuss how to shape the future of healthcare in Nigeria. We are set and ready to begin, and we're going to see how to move as quick as possible and how to make sure that we travel as fast as possible. This program today is brought to us by the Mobi Health International. I'd like us to, as we begin this event, especially and formally, celebrate the best clap that we can give the Mobi Health International. Please can we put our hands together for Mobi Health International. I'd like also especially on behalf of Mobi Health International, appreciate the Federal Ministry of Health for helping us birth this very great and amazing initiative that's about to take over the health system, and that will actually be the best as we drive towards having future for the health sector. So I'd like us to appreciate the Federal Ministry of Health. This particular request, this clap have to get to the ministry. They are not far from here. Can we celebrate the Federal Ministry of Health? So for the purpose of protocol, we have lots of people that are playing different roles in this event, but because we have to move against time, I'll be profiling people as it's their time to give their speeches or land on panel. So just permit me to quickly run to the opening remark as I especially salute and recognize the Honorable Minister of Health, who is ably and perfectly represented, and also all government leaders that we have here. I'd like to also recognize all health professionals. This is a gathering of so many medical doctors and pharmacists that we have in our midst. All our development partners that are here will also specially recognize you. The private sector individuals and key players will also specially appreciate you for coming. The civil society and everyone that's seated here to help drive this cause. Let me also salute and welcome gentlemen of the press and of course distinguished ladies and gentlemen. We'll begin very formally, and of course it's proper that we get a very warm welcome. And to do that for us is a lady, I'm not sure she has slept for maybe about the last 17 nights to make sure this event will come to a wonderful reality. I'm sure your warm welcome to her on stage will do a lot in getting her gingered, as she will also be awake the next 2 days to appreciate God for a healthy conference. I'd like to welcome the founder and chief executive of Mobile Health International. Please help me welcome Dr. Fumi Adewara.
The Honorable Minister of Health, who is unavoidably absent, but is represented here. I'm very pleased to welcome you here. The chairman of the occasion, Dr. Tunji Olulafe, who also has had an emergency at the villa. Thank you for agreeing to be the chairman of the occasion. Distinguished ladies and gentlemen, and all esteemed partners, colleagues, members of the media, ladies and gentlemen, good morning. It gives me great pleasure to welcome you all to the Nigerian Telehealth Conference, convened under the theme Scaling Telehealth for Universal Health Coverage in Nigeria, Pathway to Sustainability. My name is Dr. Fumi Adewara. I am the founder and the CEO of Mobile Health International. It is both an honor and a privilege to stand before you today as a convener of this landmark event. Permit me to begin by expressing my deepest appreciation to our special guest of honor, the Honorable Minister of State for Health, whose presence underscores the government's unwavering commitment to advancing accessible, affordable, equitable healthcare for all Nigerians. We also wish to acknowledge the presence of Dr. Mohammed, I don't know if he's in the audience yet, but maybe on his way, Yakasai, the Special Technical Advisor Programs, Office of the Special Advisor to the President on Health, who is representing Dr. Salma Ibrahim, the Special Advisor to the President on Health. We deeply appreciate her visionary leadership and the Presidency's strong commitment to strengthening Nigeria's health systems through innovation and digital transformation. We equally recognize the leadership of the Federal Ministry of Health and Social Welfare and our esteemed partners from the NHIA, the National Primary Healthcare Development Agency, World Health Organization, our headline sponsor, Afrexim Bank, who has graciously provided this venue and all the refreshments you're going to have today, NIGDA, as well as all our distinguished colleagues from the private sector, healthcare associations, academia, and the Nigerian diaspora. I want to especially also recognize the FCT Mandate Secretary, Dr. Adedolapo Pashawe. She's also on her way here. Without her, we wouldn't be here today. So she's our chief host under the leadership, of course, of the FCT Minister. To our media partners, supporting organizations, and dedicated volunteers, thank you for amplifying this vision and making today possible. Why are we here? We gather here today because we share a common conviction that quality healthcare is a right, not a privilege. Across Nigeria and Africa, too many communities remain beyond the reach of essential care. Yet, innovation gives us a new opportunity to rewrite that story. At Mobile Health International, we have seen firsthand how technology, through telemedicine and digital health, can bridge long-standing gaps in access. Our solar-powered, satellite-connected telehealth clinics are already transforming healthcare delivery in underserved communities. But today is about more than one initiative. It's about a shared national mission to institutionalize telemedicine as a key pillar of universal health coverage. Our shared vision. Together with the leadership of the Federal Ministry of Health, we envision a future where every Nigerian, regardless of geography or income, can consult a qualified doctor and specialist 24/7. Primary health centers are connected and strengthened through digital platforms. Preventative care, health education, and follow-up care are integrated seamlessly. And our health workforce is empowered with digital tools to deliver care efficiently and with dignity. This vision aligns squarely with the renewed hope agenda of the federal government, a health system strengthened by innovation, data, and collaboration. the role of partnership, and the reason why you're all invited to this event. We cannot achieve this vision alone, and we cannot achieve it in silos. It will take deliberate partnership between the government and the private sector, development agencies and academia, diaspora professionals and local innovators, all working in sync towards universal health coverage. Together we must ensure that telemedicine is not just a pilot or a project, but a sustainable, nationally adopted solution that transforms the way we deliver care. So today is a call to action to everyone in this room. As we begin today's session, I urge every participant to think boldly and act decisively. How can we accelerate and integrate telemedicine into every primary healthcare facility? How do we leverage data of disease surveillance and health planning? How do we equally ensure inclusivity, that no Nigerian is left behind in this digital health revolution? Let this conference be remembered, not for speeches, but for resolutions and actions that lead to finalization and implementation of the National Telemedicine Guideline. Once again, I thank you all. I thank the Honorable Minister for this visionary leadership, our partners for their steadfast support, and every participant here today for being part of this defining moment in Nigeria's healthcare journey. May we leave this conference more united in purpose, more determined in action, and more inspired to deliver a healthier, more connected Nigeria. With that, it is my honor and privilege to formally declare the Nigerian Telehealth Confrence 2025 open. Thank you. God bless you, and God bless the Federal Republic of Nigeria.
Thank you very much. We appreciate the Mobi Health International for this very great initiative. I should particularly send our gratitude to the founder and CEO, Mobi Health International. One more time, Dr. Mrs. Fumi Adewara. Please can we put our hands here for her one more time? Let's do that. We have good message that was sent to be played on the screen.
Hello everyone, it's a pleasure to join you all at this very important event focusing on scaling telehealth for universal health coverage. Over the next 2 days, participants, panelists, and a number of people will come together to address key issues that have implications not just for this event, but more importantly, for how we move forward with health service delivery in Nigeria. I particularly look forward to the expected outcomes, some of which will culminate in a resolution that will go to the National Council on Health later this month. So on behalf of myself, my colleagues at the Sub-National Commissioners of Health, we welcome you all and we look forward to a most fruitful meeting. Thank you.
Okay, thank you very much. We'll try to move very quickly with the good messages. I will now invite DG of NCDC, Dr. Jide Idris, here represented. It's time for the goodwill message of NCDC.
Distinguished ladies and gentlemen, I bring greetings from the DG NCDC. Unfortunately, like Dr. Adewara said, he's unavoidably absent, but he brings his welcome, he brings his greetings, and he sees the conference as very important, particularly understanding the convergence of the use of technology right now for health security, national health security. As you're aware, Nigeria is constantly managing multiple health security challenges, many outbreaks. As we speak, about 6 to 8 outbreaks that are concurrently ongoing, and the use of telemedicine and e-health is critical in helping bridge that gap. We also know the syndrome of the low headcount for healthcare workers in country and how we have to bridge that gap. So the DG brings greetings to say that this is a very critical point in our national landscape, and this is looking forward to some of the deliberations here, how this truly will shape and help improve national health security, how we can bring conversations, engagement to foster the movement of investment ideas into national health security. Do have a wonderful conference, and thank you.
Thank you very much. That was a wonderful good message from NCDC. We will now take from HFN, the Healthcare Federation of Nigeria, and to speak for the Healthcare Federation of Nigeria, I'd like to invite Regan Rula.
I bring you warm greetings from my president, Dr. Njide Ndili, who is unavoidably absent. She sent her greetings, and I'll just quickly read out her goodwill message. On behalf of Healthcare Federation of Nigeria and Farm Access Foundation, it is a privilege to join this distinguished gathering of leaders and innovators advancing Nigeria's telehealth agenda. At Farm Access, we believe that technology is a powerful tool and catalyst for equity, bridging gaps between patients, providers, and payers to make healthcare truly inclusive and efficient. The theme, Scaling Telehealth for Universal Health Coverage, Pathways to Sustainability, could not be more urgent or relevant. As we seek to strengthen our health system and extend quality care to every Nigerian, regardless of geography or income, telehealth stands out as a transformative tool capable of bridging the access gaps, unlocking efficiencies, and enabling data-driven care. Our mission remains to build trust in healthcare through quality standards, digital innovation, and sustainable financing models. As we collectively strengthen Nigeria's health system, let us continue to forge partnerships that expand access, enhance affordability, and ensure accountability. In my capacity as President of the Healthcare Federation of Nigeria, I also see immense potential for collaboration between Mobi Health International and HFN in advancing digital health integration, capacity building, and private sector engagement towards a stronger, more resilient health ecosystem. Thank you and congratulations to Mobi Health International, the Federal Ministry of Health, and all partners present for championing this, for championing this transformation journey towards a more connected and equitable healthcare future. Thank you.
It's now time for our keynote address. But just before we do that, I've just been told that our mandate secretary for health is in the building. So I think I like all mandate secretaries of FCT. When you invite them to the event, they will tell you that they're not just here alone, but they're here to represent all other mandate secretaries and the FCT minister. So it's obvious that the FCT ministry is represented here, from the minister to the list person in FCT, and to speak on behalf of the Federal Capital Territory. I'd like to invite our mandate secretary, Health. Please help me specially invite Dr. Adedolapo. Pastor, please can we put our hands together for her? Can that clap be 10 times louder?
Good morning all, and welcome to this delightful conference. I see a lot of faces, some my friends, some my teachers, some my colleagues. I have to leak on Dr. Arobundade. We did house job together. And I'm not surprised he's here, because right from then, we didn't have phones, we didn't have those things, but he had a way of taking like 3 calls. When I want to go home, I'll give him my call and he'll take it. So I don't know how he did it, but kudos to you. You're here again. Now, telemedicine is not new. If we think about what happened during Corona, we conquered that war with telemedicine, contact tracing, treatment, etc. And in doing some literature review, I got to find out that actually in 2006, this country, Nigeria, Federal Ministry of Health, partnered with National Space, something, you can find it, to launch the first digital telehealth system. I wonder what happened to it. The truth is, I will not tell you that that is all we need, because we need empathy We need a human touch. We need to see the people we're talking to. But in the absence of that, for example, right now, resident doctors are on strike. I'm happy to say I have a partnership with Mobi Health, and I have the first ever booth in Dutse Makaranta Primary Healthcare Center. And because of the strike, there's a long queue. And I start to think that this is sustainable. Why would someone go to Asokoro because the nurse on duty suspects pneumonia just because she's coughing? And say go and take an x-ray, she would have to, the cost of travel, cost of time. But if you're talking to a specialist on the other line, he knows what to ask you. There's a book called Where There Is No Doctor. We all studied community health. We had community health postings. And I believe that the thing with Nigeria is, I'm a government worker. The renewed Hope administration is trying to switch from a linear economy to a secular economy. And in a secular economy, there are no gaps. There's a complete circle. But with telemedicine, we have gaps right now. Who regulates who? If a doctor tells you, take glucophage, 2 tablets, once a day, and you mix up your glucophage with paracetamol, and then you go into a hypoglycemic coma, who do we hold responsible? Do we start to check your phone and say, oh, somebody told her to do this and that? So we need regulations, we need policy, and we need accountability. And I'm happy to say, in the FCT, we have all of that sorted out. I close by saying, the strike is biting hard, but the consultants are in the hospital. From Dutse Makaranta, you can talk to a cardiologist, you can talk to a neurologist, you can talk to a pediatrician without spending a dime. I'm also happy to say that our health insurance scheme has considered all pregnant women vulnerable. And in considering them vulnerable, they have free health insurance. They deliver for free on the condition that they attend antenatal health care. And the last joint meeting we had, FCT's skilled birth delivery percentage was 25%. Facts again from the Federal Ministry of Health, we're at 102% right now. And this is because when we say it, we do it. When you come to our centers, you get what we say you will get. I close by thanking my health insurance director, Dr. Belgore. She's right there. Stand up, Dr. Belgore. And for the first time in the history of this country, I have another state paying me for their pregnant women. Because people come from, what's that state, Nasarawa, to access healthcare here. So we had a meeting and had a handshake with the Commissioner for Health and the DG Health Insurance Scheme. And this brilliant lady came up with, why not? We're trying to reduce maternal mortality, not only in Abuja. If we reduce it in Abuja, by the time we go on the national scale, it's probably 0.000 something. It doesn't work. So you're welcome from Nasarawa as long as your HMO pays. And we're the only health insurance system that is prepaid, not postpaid as of now. Please fact check that. Thank you very much.
So first will be the good old message from the Federal Ministry of Health, and after that we'll now take the keynote address from the Minister of the Federal Ministry of Health. For our good old message, I will invite from Department of Planning, Research and Statistics for a very quick good old message from Federal Ministry of Health. Let me invite Dr. Ijal Olubenga. Please can put our hands up for Ijal Dollar, please. Can you clap a little louder for Dr. Dollar Olubenga?
Thank you very much. The representative from the Regional Minister of State for Health, the Mandate Secretary, distinguished ladies and gentlemen, please permit me to stand on the existing and established protocol. On behalf of the Federal Ministry of Health and all its related and relevant departments, it's a great honor to deliver this goodwill message at this particular important event. Today we gather for the Nigeria Telehealth Confrence, a milestone event highlighting our commitment to the use of digital health innovation to improve healthcare in Nigeria. We are all familiar with what we plan to do as part of our goal and objective for this current administration to reduce physical and financial pain, to improve healthcare system, and to save lives. The theme of this event, Scaling Health Telehealth for Universal Health Coverage in Nigeria, Pathway to Sustainability, underscore our nation's journey to equitable, accessible, and affordable healthcare for all. We are expected not to leave anyone behind. Technology is a powerful catalyst for transforming health system, and telemedicine is a present reality that can bridge human resource gap and connect under-deserved community to qualify medical experts. We just get the testimony from FCT, and we believe that we are on the right track to do that. The Federal Ministry of Health and Social Welfare has made remarkable progress in partnering pilots, digital health innovations to improve healthcare in Nigeria, and we believe that telemedicine is transforming our healthcare system by increasing access to medical care through the use of various tools that are applicable in country. This approach, we believe, will benefit rural community in several ways. We help us to overcome our limited facility, the long distance, reduce hospital congestion, and enable better follow-up care for patients, especially with chronic conditions, and also improve on health education and awareness while we are trying to save costs. We are also familiar with the challenges that we'll be facing. What we have been facing over the years in terms of improving digital health in Nigeria. We know about the issues with infrastructure, the connectivity issues, the literacy, and the patient acceptance concern. And also we talk about regulatory and policy barriers, the issue about the security and the privacy concern. All this and what we are working on to unlock its full potential by developing clear guidelines and regulations to ensure that what we are producing, what we are giving to Nigerians are of quality, have the necessary security, and also promote privacy. The government, through the ministry and the private sector and all other key stakeholders, are working together to ensure that we integrate telemedicine into our national healthcare system and drive innovation in our digital healthcare services. We believe that this conference provides a platform for us to provide the necessary input into the National Teleconference Telehealth Guideline, and we believe that this will help us to be able to improve on our policy footprint for integrating telemedicine into our healthcare system, focusing on the standard, the regulation, financing, and digital infrastructure, and the workforce readiness. I would like to appreciate Movie Health for convening this important event, and we believe in collaboration with all our key stakeholders across the country, we believe that we're on the right path to improve healthcare system in Nigeria. Thank you very much.
We'll now go straight to our keynote address. The keynote address for the Nigerian Telehealth Conference 2025 will be given by the Honorable Minister of State Health, Honorable Dr. Isiaq Salako. who is here perfectly represented by the Senior Technical Advisor on Digital Health to the Honorable Minister. I'd like to specially welcome Dr. Oluniki Ujewale. Please, can we put our hands together for the Minister?
The Mandate Secretary, Federal Capital Territory, distinguished directors, esteemed development partners and donor agencies, representatives of the National Health Insurance, NHIA, representatives of MPHCDA, other NDAs here present, leaders of professional and private health associations, members of the press, distinguished guests, ladies and gentlemen. It is my great honor to deliver this address on behalf of the Honorable Minister of State for Health and Social Welfare, Dr. Isiaq Adekunle Salako. At this important event, we gather today for the Nigerian Telehealth Conference 2025, a milestone event highlighting our commitment to digital health innovation and sustainable healthcare delivery for all Nigerians. The theme of the conference, Scaling Telehealth for Universal Health Coverage in Nigeria, Pathway to Sustainability, underscores the nation's journey towards equitable, accessible, and affordable healthcare. Technology is a powerful catalyst, as we all know, for transforming health systems. And telemedicine is not just a vision for the future. It is a present-day reality, like the Mandate Secretary alluded to, that sort of bridges the gap with the human resource gaps and connects underserved communities to qualified medical experts. Under the renewed hope agenda of the President Bola Ahmed Tinubu, GCFR, the bespoke Nigeria Health Sector Renewal Investment Initiative aims to transform our country's healthcare system. The implementation and eventual success of this initiative hinges on the Nigeria Digital Health Initiative as a core pillar of implementation, championing a unified and secure health data architecture that supports this vision. This year's Telehealth Conference marks a significant milestone in our collective journey towards a digitally enabled health system. It provides a national platform to showcase, test, and as well validate innovative telehealth and digital health solutions across key areas, including e-prescription, immunization tracking, maternal and child health referrals, and claims management systems. Through these efforts, interoperability becomes more than a technical goal. It ensures that no data point, no patient, no community is left behind, and the seamless exchange of health information that strengthens our healthcare delivery system, decision-making, and resilience. We acknowledge that challenges persist, ranging from fragmented healthcare data systems, infrastructure, connectivity limitations, to issues of digital literacy, patient acceptance, regulatory frameworks, and data privacy. The Ministry of Health, in collaboration with the private sector and development partners, is working tirelessly to establish clear guidelines and robust governance mechanisms to ensure quality, security, and trust in telemedicine and digital health services. As we proceed on this remarkable and landmark journey, this conference aims to provide a platform to validate and align the National Telehealth Sustainability Framework, which will be presented at the forthcoming National Council on Health meeting later on this November. The framework serves as a policy blueprint for integrating telemedicine into our healthcare system, addressing standards, regulations, financing, digital infrastructure, and workforce readiness to ensure sustainability. I wish to express the Federal Ministry of Health's deep appreciation to our development and technical partners, the conference co-hosts, Mobi Health, and collaborators for their steadfast support.
I also commend the private sector, because without the private sector, we really cannot move far. Innovators and the planning committee for these tireless efforts. Together, through the renewed hope agenda and collective national commitment, we can harness technology to build a resilient health system, one where no Nigeria is left behind in assessing quality healthcare. So I wish us a fruitful deliberation. God bless you. God bless the Federal Republic of Nigeria.
Thank you very much. Especially appreciate you for speaking perfectly on behalf of the Minister of State for Health of the Federal Republic of Nigeria, Honorable Dr. Isiaq Salako. Thank you very much. It's now time for us to dive into some other areas of the conference. First, we'll look at, before we get to our first panel, we'll be looking at the WHO's position on the implementation of telemedicine in Nigeria. What's the position of the World Health Organization on the implementation of telemedicine in Nigeria? I'd like to invite to speak for the World Health Organization. Let me especially invite pharmacist Nkiru Uko from World Health Organization.
The Honorable Minister of State for Health, all dignitaries here present, please permit me to stand on existing protocol. On WHO's position on implementation of telemedicine in Nigeria, for us at the World Health Organization, we have a supportive stance towards the implementation of telemedicine in Nigeria, and this is evident from the support that we have provided so far in this area, and also in consideration of the provision of guides and tools globally and in the region to support the implementation of telemedicine everywhere, and then specifically in Nigeria. For this, we always advise to move for the framework for implementation, and this framework for implementation entails strong governance. For Nigeria, we recognize the strong political will we have at this time by the establishment of the or inauguration of the Nigerian Digital Health Initiative that was launched last year. And with that, WHO believes that Nigeria is very fertile for the implementation of telemedicine and other telehealth services, and also digital health in general. WHO also supports the need for careful planning in the implementation of telemedicine services in Nigeria. Careful planning in consideration of health services, what is available, what is the supply like, what is the demand like, where the gaps are, and which services can we actually provide virtually, considering the pros and the cons of delivering services from a distance. WHO anchors this on the belief that telemedicine is one sure way of moving towards universal health coverage, because we recognize that with the current state of things across the world, and particularly in our climate, it is almost impossible to reach all those that can be reached. So we align this on the universal health coverage, which means that no one should be left behind, meaning that accessibility, quality, sustainability of services should be prioritized, noting those that are vulnerable or those that are limited in one way or the other. And we advocate for the use of global standards, and for that we have developed a lot of that on telemedicine standards for effective and equitable services through telemedicine. We also advocate and encourage alignment with the National Digital Health Strategy, which also prioritizes telemedicine as one of the ways to help the country move towards universal health coverage. We also encourage and advise for capacity building, because where you have health workers or even beneficiaries that do not understand how to use the devices available, if it is available, and also how to take these services through technology, that may be a limitation and even a bit retrogressive. We advise for the alignment to the laws of the country, such as the data protection and privacy laws, to ensure patient safety and confidentiality, and also in aligning to standards, extant standards and guidelines, because one of the key issues or key challenges is the liability exposure of providers in terms of medical error in providing telemedicine. We also advocate for integration with national systems, meaning that telemedicine should not be a standalone, but an effort made to make sure it's integrated with the national system to ensure the continuity of care, to improve outcomes and overall efficiency of the healthcare delivery system. We also advocate for evidence-based decision-making, where we promote the use of data and evidence to inform telemedicine policy and decision-making, ensuring that these services are grounded in the best available research and evaluation. For this, this is what WHO stands for, and WHO is confident that Nigeria is very ripe and even actually overripe and really needs telemedicine services and other telehealth services to advance towards universal health coverage. Thank you very much for listening, ladies and gentlemen.
Thank you very much, Miles. Especially appreciate you. We'll be going now straight for the first panel.
Thank you very much. It's a wonderful morning. Almost everybody on this panel has one way or the other touched the lives of Nigerians, and we all know. But for the benefit of those of us that may not be very familiar with our work, we have 2 minutes. I'm going to speak the Managing Secretary. She does the introduction for them. So I'm going to start with my representative of the NMA President, Dr. Moses.
Good morning, everybody. The Managing Secretary, good morning to you. My name is Dr. Benjamin Oluwatosin. I'm the first Vice President of the Nigerian Administration, and I'm very glad to be here today. Telehealth is very, very critical in national coverage now, and access to healthcare will be hinged on technology going forward. I'm glad that this is coming to discussion on the forefront, and all of us in this room are stakeholders in making this happen. And as NNA, as doctors, we want to be very relevant and very participatory in discourse. Ethics, standards are very, very important, especially to those that are in your own community, so they're not taking advantage of very often. So I'm glad to be here today to have done Mr. President. Thank you for having me. Thank you.
Good morning, everyone. My name is Dr. Amina Mohammed Balouni. I'm a public health physician with special interest in health system strengthening, systems, telemedicine, digital health, and I chair the board of SEDA, which is Solina Center for Development and Research. Thank you.
Good morning, everyone. My name is Dr. Kumi Adewara, the founder of Movie Health International. It's a privilege and an honor to convene this conference in partnership and collaboration with other stakeholders, especially the Federal Ministry of Health. Thank you.
Good morning, everybody. All protocols fully observed. My name is Oluwatosin Adedogun. I'm a public health physician by training. I have the privilege in the last 18 years to have worked in the digital health space, supporting the development of some of the most notable solutions that are used in the HIV space in Nigeria. I currently work as country director with DAO Systems, a digital solutions company, fully registered in Nigeria and supporting the Nigerian program. Thank you very much.
Good morning, everyone. My name is Dr. Badmos Solari. I'm a senior associate at Health Ethics and Law Consulting. I've over the past 11 years had the privilege of working in the digital health space, developing regulatory frameworks around digital health space. So, Health Ethics and Law Consulting first, and the leading law firm focused really on the health sector, providing unique and boutique advisory to the health sector space. So it's a pleasure being in this panel of discussion. Looking forward to the discussions. Thank you.
Good morning again, ladies and gentlemen. My name is Nkiru Kaiko, and I work as a health systems expert in WHO Nigeria. My work cuts across health information system support to the government of Nigeria and stakeholders, and in health research systems capacity strengthening, and in digital health and innovation. And this has got across the last 2 decades, working at the subnational level and at this level about a decade. Thank you.
We all know telemedicine is an exciting subject. It serves to bridge the gap of location. And one of the challenges in the Nigerian landscape, healthcare landscape, is access. And we're trying to talk about scaling up telehealth to reach access. So one of the things that happen when you use telemedicine is that you have consultation taking place virtually, and you cannot confirm the identity of the person that is providing the care at the other end. My question to you would be, how will NMA ensure that it is ethical and that the disciplinary frameworks are harmonized with the national telemedicine law?
Thank you very much, Dr. Robinelli. I believe it's important that MSD and Medical Dental Council of Nigeria, with the NMA standard, is used as a framework to get into the portal. So, we're thinking about it from the enemy, that we must also utilize our standard, so that when a doctor is supposed to be seen, there's a verification code that we get on the platform that says this doctor is a medical doctor. Right now, anybody just go on the internet, you see people talking on Instagram, talking everywhere, even on Facebook, saying they are doctors, or some kind of names. And because a lot of Nigerians are very gullible to this kind of information, this nationalism, they just think they are doctors. So for us, an enemy, ethically, we're trying to use the Medical and Dental Council with the standards that doctors should have. I know every lawyer understands. Now in Nigeria, now every doctor has a standard. So if all of us now understand that as stakeholders, that for you to confirm this is a medical doctor, you ask for the stamp of the doctor. That gives validation for the person you're seeing on the other side of consultation. And it's important also we know how far, what kind of training these doctors are right now, because of the issues of war in Ukraine and Russia and stuff. A lot of people are coming back to the country and didn't finish their job, I didn't finish their medical school in this place because of the war, and they think they can practice like doctor. So for us, it's important clarity, ask the right questions as patients, and everybody on this conference will know that this doctor has an NSPL license and a digitalized stamp, and that's why it qualifies to ask you questions. You all know that there are a lot of issues around the healthcare sector. People are saying they want to become consultants, even if they are not medical doctors. And because of that cliche or that title, they can start using that title to access patients, telling them you can see me because you can make money over 10 years. So it's important for us that there is moderation, there is proper accountability for who and who are those on the platform. And this certified properly. I think the frame of what they're saying they can do, what is the capacity But the questions they are asking you, hopefully, I don't know AI doctors or using Google to doctor you. Is there a relationship that you can feel the empathy for medical? So it's a powerful that way. This meeting is critical. I know you understand that a doctor has empathy, but care does not have empathy because they don't talk anything. Thank you very much.
Thank you very much for that. That's amazing. So the key thing to take away there is that the LMA is working with NGCL to create it. As a matter of fact, I'm aware that the register is actually created as we speak, that can be verified in real time, and you can tell the identity of the persons. Okay, having said that, I'm going to go to Dr. Adego next. One very critical part of telecom consultation, telehealth generally, is the exchange of data. And data, I say these days, is life. So how do we ensure that whatever guidelines we come up with ensures that data is appropriately protected and is used for actionable policy making?
Thank you very much. I think the first thing is that in coming up with our guidelines, we need to ensure that it aligns with all the statutory frameworks that in country, from the Federal Ministry of Health, from the National Data Protection Agency, so that those guidelines align with that and align with global best practices. And having done that, we need to create an incentive for telemedicine providers to ensure that they develop their systems in such a way that those guidelines, those frameworks are implemented in setting up their telemedicine platforms. That way, there is adequate provision for data security, for privacy and confidentiality, adequate provisions for using appropriate encryption technology in transmitting data to relevant platforms as may be required for national level reporting. So once all those, the guideline clarifies the standards that needs to be established and the partners ensure those guidelines are established, it would ensure the safety of the data to start with. But beyond that, there needs to be incentive for the providers to align their systems with those guidelines. And to provide that incentive, one, we will kind of like set up like an accreditation process whereby providers are accredited by a committee led by the Ministry of Health, NICTA, and all those other statutory bodies, accredited to provide those services. Accredited service providers should be published on the website of these organizations so that the public knows accredited organizations. You can take that a step further by providing certification, whereby there's a tiered level of certification based on the level of conformance to those standards. And so you can have a stamp that says I am level 1 or I am level 2 or level 3, which you can display on your website, you can display on your platforms, which boost the specialist confidence in what you have to offer. Thank you.
Without taking any more time, I'm going to go straight to Mr. Badmore's doctrine. We talked about data and we talked about how we can tier the different levels of certification to ensure that. But what I want to ask you is this: what legal provisions must the guideline, include to ensure that we get adequate consent, we have data sovereignty, and that the people are actually compliant with whatever level of certification that we require them to comply with?
When we speak about consent, I can talk about consent when I want to, because consent, I would say there are two basic types of consent, right? So there's consent as relates to data protection, right? Data protection and privacy, which relates to information privacy. Now there's informed consent that relates to doctors as relates to asking the patient, giving the patient the freedom of autonomy right, to decide the level of care on whether or not he wants that care, the treatment plans and options. Now, because in practice, when I've been working in this space, right, I've seen telehealth platforms somehow mix up these concepts, right, and that creates a dilemma, right? So, information privacy constraints. Normally, you can display a privacy notice on your platform, right? That shows okay, yes, you are collecting this information through consent. The purpose for which you are collecting it, the identity of the person, the reasons, storage limitation, the right of the person, the right of the data source, that is the patient to use to withdraw their consent if they want. So so what I'm trying to say is that the guidelines should take into consideration the two different types of consent under data protection as relates to information privacy and consent for informed consent. That's one. Then secondly, the other one I would say is age, consent as relates to age, right? I don't really think there's much dilemma in that because I think the code of medical ethics and those judicial decisions have to like that, right? So I think 16 to 18 really can give consent, yeah. Then from 13 to 16 really I think it's an aspect, yeah. You can give a valid assent, but you must document it if they're able to understand the care and the level of care you intend to provide for them. You can actually give consent. Then also I think from ages 13 below is where the dilemma might come up because I think different cases have not explained that if it's in the interest of the child, then you might, if it's in the interest of the child, you might actually go and get a court for that one and treat that child, or you might decide to, if it's an issue of life or death, you might decide to treat that child and obtain court order. So this intricacies is one thing that I think that should be at least replicated in the guideline. That's for consent. Then also maybe another thing I think about consent is maybe cross-border telemedicine. I would say as best practice, right? Because looking at other jurisdictions, they tend to provide the same level of protection. That at least when providing care, let's say a doctor abroad, at least to inform that person that okay, yes, this is your jurisdiction, this is where you are, this is the level of protection offered there, this is the level of standard offered there. So all this should be provided for. Then so I think you mentioned
data sovereignty.
On data sovereignty, right? I think the Nigerian Data Protection Act is pretty much clear on who and for the Authority for Data Sovereignty, and that's the Nigerian Data Protection Commission, right? So for controllers, which are telehealth providers, healthcare providers who are providing services, as long as you are processing those data in Nigeria, even if you are in another country, processing data subjects, right? So data subjects data in Nigeria, they are also bound by Data Protection Act. But now there can be some intricate issues, right? Where two laws might guide the same processing. So, for example, now if a telehealth provider is in the UK or in Europe, the GDPR will also govern that processing. So, I think normally, typically, the NDPC will enter into mutual agreements as relates to that. Then, for liabilities, I would say pretty much everything can be resolved through contracts, I must confess. Because in terms of product and effect liability, if a software has been an issue, you can use contracts to say, okay, it's the software provider who is not reliable. For medical negligence, you can also say the same thing inside the contract. That, okay, any error in judgment by the healthcare provider or error in the decision making, you'll be liable. Jurisdiction and governing law, you can still do that in the contract by saying, okay, this law governs this transaction, this law governs this transaction. The only issue that I see is in terms of licensing, right? And that can, because you cannot use a contract to override the statutory provision. So that has to be now left to NDCA and the other statutory to settle. So thank you.
All right, thank you very much. The draft National Telemedicine Guidelines as it is currently requires providers to have a consent form on their platform that consumers or users must agree to. It also puts liability based on the prevailing laws in Nigeria. So thank you very much for all of that. Now we're going to my mandate secretary. I should say this, our HPT was the first state in Nigeria, quote unquote, to accomplish a national digital health policy framework. That happened 4 years, 3 years ago. We'd like to show some of the efforts that the FCT has made with regards to using telemedicine to bridge the gap for access.
Good afternoon again. And that document you're talking about has gone into oblivion. Because when mobile health approached me, I did a lot of literature review. I asked questions, and yes, I read it there 2009, so nothing ever happened. They start off from electronic medical records thing, and the consultant dumped everything and walked away. And that was the end of that. But coming back to now, I want to ask you, what is the expected outcome of this conference, of this conference?
So, one of the things that we are hoping to be able to achieve is take to a national telemedicine document that will help to ensure that we're able to improve universal healthcare access and also improve outcome, particularly for the underserved parts of the country.
So I asked you that because in government we do a lot of talking. There's conferences every day, meetings every day, and then we go home and there's nothing. I want to say here that I worked with a gentleman called Dr. Jide Idris and Dr. Olufile, and I'm happy to boast that we wrote the mental health policy for Lagos State, and it took 4 years for it to become law. And it occurred to me that really we can come up with a policy, because the policy is a statement of intention. As long as it is not clashing with concurrent or executive laws, we're allowed. And if we're able to come up with a policy here, because the highest level of policy makers in health are here, the Federal Ministry of Health, then I'd be happy about this. That's one. Sure. When we look at data protection and medical negligence and all of that, I put to you, sir, that before we even start to talk about medical negligence and data protection and rights of the patient in telemedicine, right now in what's the other side of telemedicine? Manual medicine, analog medicine. We do not even have a litigation kind of culture. People die, and the doctor takes off his gloves and says, "I'm sorry." It's social, it's religious, and it's economical. And I think those are the things we need to start looking at, even before we get to telemedicine. If we're not used to it now, we're not aware of it now, we're not aware that we do have rights. As a matter of fact, I have to put on all the hospitals in FCT that we reserve the right to refuse treatment if a health personnel is abused verbally, physically, or harassed. And we also put there that a patient has the right to report abuse or unethical practices, or if it's not satisfied. So a number, like I said, we talk to people, we need to communicate. Communication is two-way. You don't just say something and walk away. So if we draw up this policy, I know I'm not answering your question, I just want to be pragmatic. If we come up with this policy, let's throw it open to everyone. Look at it, what do you think? And I picked particularly on negligence. I've seen here the strangest things, where, first of all, the ambulance should not carry a dead body. I've not seen a hearse in our system here. Not only have I not seen a hearse, I have seen people wrapped in white in public transport, and the policeman is clearing the way, like, let him go, before sunset. No death certificate. I have seen clear coroner's cases, and they just mop up and leave. What am I saying? Knowledge, attitude, practices, awareness, even of the analog before we go to the digital. Otherwise, when you fail to plan, you plan to fail. And what we're doing in SPT now is like a proof of concept. How does it work? What are the downsides? And one of the downsides is I cannot pinpoint the person on the other end of the phone. So, the agreement we had with Mobile Health is use our doctors who are built in facilities. So, if the call is patched to Asokoro General Hospital, Asokoro General Hospital is responsible for the care of that patient, not who picked the call, who didn't pick the call. We must have a dashboard that shows us. And that's not telemedicine. That's like consultation over the phone. So, in getting, this is what I'm saying in this proof of concept. With that kiosk she put there. And I keep thinking, how do I hack this? We can only hack it with the paper we all come up with after this discussion. So there are problems, but the journey of 1,000 years starts with one step. Thank you.
Thank you very much. Amazing. One other thing I've always known about her is being pragmatic. Result oriented, and that's clearly demonstrated in the efforts there. I'm going to go next to Dr. Amina Balenci. She's the board chair for SKIDA, and they have done some amazing work, particularly in research into telemedicine and digital health. I'm aware of some of the things that they have done in Lagos with images, with Lashma. We reached over 24 words, covering the 5 billion editions of Lagos. We interviewed over 11,000 consultations. What lessons from those research that you have done can we, take into the national telemedicine level?
Thank you very much. Yeah, thank you very much for that question. Let me start a little bit of context, just a little bit, around how this implementation research was done. It was in 2 phases, and the first phase was to identify the underserved wards. There were about 64 of them, and then to analyze the landscape of telemedicine providers. And talking to the communities on their expectations. So the very important thing is setting standards. As she said, there are different standards, there are global standards. So if we don't contextualize to our own people, we may not get the desired effect. So that was done. And with that, they decided 3 models. Let's try 3 models. One was hotline, you could call a hotline and access services. There was a mobile kiosk, like what is happening in FCT, and then the community pharmacy kiosk. And after that, free service providers now provided those services in those three models. And data was collected and a lot of analysis was done so that we would find out, what was the reach, the effectiveness, implementation and maintenance. And we demonstrated that about 94% of the engagements preferred, first of all, some sort of physical place to go to. So rather than just calling the hotline, we prefer to go to the market style booth or the community style pharmacy. And then that improved their access and also reduced their travel costs. So if you have a booth in the market, you don't have to go far away to access healthcare. And the key things that were learned was that community engagement is the most effective. And that the physical type thing, the physical type thing, an actual place to go to, rather than a phone, number to call, was important for people. And that we must have some sort of onboarding. Even though people may want to use the phone later, they prefer to come to the physical place first, get enrolled, and then subsequently they access that. And most of the things were really the common element. So what is important is that if we improve the access for people, we can reach those basic elements that you provide services for at PHC level, and also gives you an opportunity to try out, see where we can go. So, of course, when you're doing that, they have some challenges. And what was found was that there was limited awareness. So people really didn't know much about telemedicine, especially at lower levels, because most of the telemedicine providers provide services for middle and higher income persons. And then because a lot of our people have low literacy, even accessing the telephone numbers was a problem, or even accessing the service provider. So if you're only going to provide in English, it's going to be a problem for some people. So you may have to do local languages. And then the most important one of all, the infrastructure constraints. We all know what happens with network when we go to certain areas. So if you don't have those, you don't have solar-powered places where you can actually access those places. And then financial barriers. Now, this is not for the actual booths, but when you triage somebody and they need to go to place, some of them don't have the money to go there, or they need to go to general hospital. So that is something that, when we're looking at regulation, we must be able to, put safeguards in place where maybe link it to health insurance to see that that part is taken care of. And of course, always we talk about data quality, completeness, and quantity. So in learning those lessons, we should look at what is the current regulatory landscape. And you have several regulatory bodies. MDCF, you referred to, is about the professional, whether you're licensed, whether the standards you follow, ethics. But then you have the protection regulation and the Data Protection Commission, which is not sitting in the Ministry of Health. So you must have some sort of interface, a coordinating body for all these bodies that have different roles to come in and talk about. But then we don't have anything about cross-border teleconsultation, and it's happening. And then how do you now hold people liable? What is the liability of the provider? What are the patient's rights? And what is the interoperability of the actual telemedicine providers and the greater public and the data repositories that we have in the NHIS, the DHIS and the NHMIS. So these are some of the regulatory things that came across that we need to do, that we need to look at how do we do equity-based models? How do we ensure that there's accountability and there's cost standards in the quality of care, like we alluded to. Everybody just sits up and sets up a website or TikTok and tells you that he's a doctor. There's no verification. And they tell you, this is the treatment for this. I'm sure your WhatsApp is plugged with lots of people sending you things about longevity, or what you should drink, whether you should stop vaccinating, and there's no regulation. And therefore there's no liability. So these are some of the lessons from the research that it's very important that all these pilots that are taking place, when we're developing the guidelines, it should take into consideration what is actually left at field level and what actually the people we're trying to reach are looking for, what they need and what is convenient for them. Or else we'll have standards, we'll have guidelines, we'll have providers, and they don't use them. So those are the lessons I think.
Thank you very much for that. I'm going to go to our convener next, Dr. Adiwara. We did hear Dr. Balogi talk about infrastructure and some of the things, some of the challenges that they've encountered. I know that Mobi Health has had its own fair share of entrepreneurship challenges in the Nigerian landscape, and you have used a lot of innovative ways to overcome them. So innovation is there, to help to overcome some of these challenges. But then there are regulations, and like you said, regulations are required to protect us, from the TikTok doctors that ask us to use salt and water to cure Ebola and coronavirus. Now, sometimes we know that as important as regulations are, they get in the way of innovation. How do you want us to manage it?
Thank you very much, and thank you all for the very wonderful contributions and insights that you have shared. I think what is important is to have a regulatory framework that allows startups to innovate while protecting public safety. It is very important because, as you know, currently one of the major barriers to access today is the critical shortage of doctors. So if Nigeria has less than about 20,000 doctors to a population of 230 million people, 250 million people now, right? Okay. So, and we have over 50,000 Nigerian doctors spread across the world. So if the regulator is going to come in and say, I need XYZ in place, and anything that stifles innovation, then we may not just be shooting ourselves in the foot. And that gives room for the TikTok doctors and the anabos and Google niches to continue to provide care to these patients. So I think it's about balancing act, ensuring that the regulations that are put in place are pragmatic, because what is the other option if this doesn't happen, right? Right now, millions of people are dying. So I think that's something that is very important to put into consideration. And of course, for us, from our experience, we've been able to circumvent some of these bottlenecks. When we started off, we spoke about different access points. We knew from start that we had to provide a solution that had a physical element, that trust, the fact that Nigerian patients want to be taught, felt, and all that. But, and so we have to provide telehealth hubs that have solar power, that have satellite, that have trained operators, that have point-of-care diagnostics, and that have medicine, so that you're able to provide an end-to-end solution. But also recognizing the fact that an average patient cannot afford, the cost of data is about 6 times what they pay in the West. And if the patient has to struggle between paying for healthcare and having data, then that's a problem. So we implemented the telemedicine clinic, and in partnership with the FCT, we're putting in solar panels and satellite. But when it comes to regulation, how can the government ensure that every validated telemedicine portal comes Wi-Fi free? Somebody has to swallow the bill, for who on the government side. Importantly also is the issue of reimbursement. If there's no clear regulatory framework, around licensing, whether it's cross-border or interstate, whether it is about the jurisdiction, if there's a medical legal issue, where's the jurisdiction of choice? Is it Sokoto? Is it Kano? Is it London? And if you require for every telehealth provider to then have license per state, how cumbersome can that be? If you're trying to bring in 10,000 doctors from the diaspora to come in and provide care, how are we going to license them per state? Can we have a unified license that allows them to practice? Right. So, and around reimbursement, the FCT, one of the ways that they have been able to practice is to integrate it into the FCT health insurance scheme. And that's one of the things that we are advocating for, that a memo can go to the National Council on Health to have some reimbursement of telehealth, telemedicine within the National Health Insurance so that it becomes reimbursable and it can drive adoption to the last mile. I don't want anybody to be under the delusion that we intend to have a perfect telemedicine guideline from the start, but we can start off from where we are and then build incrementally from there. Thank you.
Thank you very much. So without doubt, nobody starts out perfect. I'm being informed that we are running out of time. But not before we hear from WHO, just to wrap it up, WHO has had a lot of experience across the world, particularly in Africa. We are talking about the National Telemedicine Guideline. What should we be looking for beyond that, particularly knowing that we have a National Health Act 2014? How should they be speaking to one another? From WHO's perspective across Africa.
Yeah, we know that a guideline is not a law and is not a policy. It is just set of standards, protocols, to guide or to inform on what should be done for both the providers and the people that are going to use it. And that's also to help to ensure accountability in the side of the practitioners on what they're expected to do. But having that, it's not the answer to really having telemedicine implemented in the country. We advise and advocate for the country in strengthening the legal, the legal basis, the regulations for implementing telemedicine. Currently, yes, we have the National Health Act, but is it explicit? Does it explicitly state or make statements on telemedicine? And if it doesn't, why does it need us? Now that takes me to the issue of we have the guideline, and as much as possible, we try to make sure that the guideline, supporting the ministry, covers all that it should cover. But the next step would be to have those regulations brought out. And those laws or the regulations is what also is going to guide what we are going to be implementing in terms of services for telemedicine, aligning to what we have as a country. So for us, the next step will be that as the country is launching and disseminating and understanding what this has, then the issue of this is how it is going to be done, but what needs to be done. The other panel members have spoken about issues of interoperability, issues of around cross-border teleconsultation. They have spoken about issues of a lot. Now, that's why you need to have something like these laws to guide how those things should be done. And also the issue of liability of exposure of the practitioners in data processing. Those things are very important. We know the country has the National Data Protection and Privacy Act, but that's general. Does it cover all that needs to be covered if we need to implement telemedicine in the right way? An example is what Dr. Fatima said about the issue of cross-border teleconsultation. Now, for that cross-border teleconsultation, there is a lot that is needed to make that happen and happen seamlessly. And one of that is having an agreement bilaterally with the other countries. How do we come about that if we don't have a law from our side, and even integrate it into a global trust network for that kind of thing to happen? A global trust certification and kind of credential verification network. Those things need to be backed by law. And then on the issue of like accessibility, the usability and equity in the use of telemedicine services, that also needs to be brought out and then spelled out how it is going to be done. If a telemedicine service does not have anything that can help those people with disabilities, what happens? Because they can't be excluded. Telemedicine services is meant to ensure that nobody's left behind. There's accessibility and all that. So how is it going to be done? It needs to be spelled out. Today, the Nigeria Digital in Health Initiative, they are working towards standardizing the EMRs so that we can have continuity and care connection and all that. And that actually is going to improve quality of care and the outcome. Now, that needs to also be integrated into a legal basis for telemedicine. So what I'm saying is that guidance is good. It tells me what I need to know. It tells me what I need to do. But it does not, it's not a law. It is not a law. You can't, it doesn't say what happens to me if I do not do those things. So now we have the National Health Act, like you said, and we have the Privacy Act, and we have all those other documents. But the question we will ask is, having understood the length and breadth and the scope that telemedicine services can offer us, are there enough? Now, if the answer is that they are not enough, considering all this that I've said, the issue of sharing data, interoperability, the issue of patient privacy, the issue of accessibility, the issue of cross-border teleconsultations, all those things, and even how we pilot, how we invest in telemedicine, those things all need to be considered. So if we look around with our experiences and we think that they are not enough, that means that we need a law, we need another thing to guide that implementation and to make it more effective and safe for everybody, both for the practitioners and the beneficiaries of the services.
Thank you very much for what has wonderful talk and being asked to round this up and in the interest of time. I'm sure we will have more panel sessions and we'll to address a lot. I want to say a special thank you to everybody that has been a part of this. We're able to unearth quite a number of issues. Thank you to the mandate secretary for time and some of the expositions she did there. Thank you very much for listening to us. Have a beautiful morning.
I invite Director of Hospital Services from the Federal Ministry of Health to do a very special presentation. That will be for very few minutes. After that, we'll take Cedar, then Mr. Brian, Diva, and then we'll go to our next presentation. I recognize Dr. Umar Tanko Yakasi. Please can we put our hands together for Dr. Umar? Dr. Umar should be somewhere. Where you at, sir? Oh yes, can we clap for Dr. Umar? Thank you very much. Sir, while you're ready, so we'll take from Federal Ministry of Health, Director, Hospital Services, for a very quick presentation.
Good morning, ladies and gentlemen. Good morning, everyone. I am glad to be here and to be a part of this discussion. I'm Dr. Abisola Adegoke, MNI, Director in charge of Teaching Hospitals Division in the Department of Hospital Services, Federal Ministry of Health. And I'm here this morning to stand in for Dr. Salahuddin Olawale Jimoh, who is on another official assignment and is unable to be here this morning.
The discussion we're having today, honestly speaking, is a good one because we are on course. As far as medicine is concerned, it's been said now that the world is a global village. And apart from that, we do not even have enough doctors, to cater for the masses that, need medical help in one way or the other. So I want all of us to pay close attention because there's a lot to learn, to unlearn, and to relearn this morning. I want to congratulate the convener, Dr. Fumi Adewara, for this laudable initiative. I want to appreciate each and every one of us that are seated here this morning. You are all important, and highly distinguished guests. I also want to thank the press, the media. For me, it's a good one for us to be a part of today. And this presentation that is coming our way, well, if you want to tag it, it's an overview. Because as far as the Department of Hospital Services is concerned, we also have a division in the department, that is e-health. And e-health has been working closely with mobile health and all other relevant stakeholders. Someone also is here, in person of Dr. Benga Ijaudola, who is also here standing in for Director of Health Planning, Research and Statistics. Let me tell us that the discussion we're having today, the ministry is very much interested in it. Remember that the guidelines, also is domiciled in the ministry. And so I want all of us to, be a part of this discussion. And I'm going to be giving us an overview, a background, we'll talk about, the people that I've been collaborating with. I will also make mention of some of the challenges and proffer, recommendations. And even with that too, it will also broaden our mind so that, in Kuru, when you identify problems and you talk about the challenges, it's expected that you talk about recommendations. And you don't just stop there, you also must include implementation strategies. So, whichever way you have to come in whatever capacity, please, we all have something to offer. So thank you very much. And so I want to quickly, tell us about the current status of telemedicine services in Nigeria. And so permit me to stand on already established protocol. Let me align myself with it. And I'm here to tell us that telemedicine is no longer a futuristic idea in Nigeria. That is the truth. It is a growing reality that is gradually redefining how we deliver healthcare, bridge distance, and ensure equity in access. Nigeria seeks to achieve a digitally enabled health system that is efficient, equitable, and people-centered. And as part of the ministry's digital transformation agenda, telemedicine is being mainstreamed into national health programs under the Department of Hospital Services. And just as I've also mentioned, it is being coordinated by the e-health division. And the ministry is working closely with relevant ministries, departments, and agencies, such as National Information Technology Development Agency, NITDA, National Health Insurance Authority. Remember, you really cannot go far unless there is money. Out of pocket is very expensive, and so there is need for NHIS, now NHIA, to come on board. And so the ministry also is partnering with NHIA, National Space Research and Development Agency, NASDA, National Data Protection Commission. Same also with Medical and Dental Council, We have partners such as World Health Organization, civil society organizations. We have them like Telemedicine, Society for Telemedicine, and eHealth in Nigeria. And so together with these partners and MDAs, we are developing national telemedicine guidelines to ensure seamless practice. And as of 2025, I can make bold to say, and many of us, we know this, that telemedicine services in Nigeria, they are functional, though at varying scales in both public and private healthcare facilities, both in the federal and the subnational levels. We are aware that some clinicians are conducting video consultations with specialists hundreds of kilometers away, and this is a powerful reminder that digital access can be achieved when infrastructure, regulation, and political will, when they align. I want us to clap for the federal government, please. We are looking so serious. Please clap, 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 and clap for yourself too, for being a part, of this story today. And so to sustain these gains, the Federal Ministry of Health, through the eHealth Division, is advancing in developing a national telemedicine guideline alongside relevant stakeholders that have earlier on mentioned. The ministry also is working on digitization of hospitals, electronic medical record harmonization, and interoperability frameworks to ensure teleconsultations integrate seamlessly with national health information system. And I also can testify that in the Department of Hospital Services, because all the federal tertiary health institutions, they're about 84 in number, teaching hospitals, federal medical centers, and specialty hospitals. From time to time, we do engage them by asking them, how far have you gone? What is the percentage? What challenges are you having? How can it get better? And I'm sure some of them, they are already, they are almost there, because I do not want to say that they are there, because there's always room for improvement. And if there's also something that I'm also sure of, as far as interoperability is concerned, the Department of Hospital Services is also doing a lot regarding that. Because you may have a patient who has been receiving treatment in Lagos, and then for whatever reason, the person is in another part of the country. So the person, should be, the clinician should be able to have a conversation, or at least have the relevant, records about how the patient is being managed. It will only enhance, the healthcare service that the patient is to be, is to have. But are we there? I said no. And so there are challenges. And if there are challenges, then there certainly must be, solutions or recommendations. And so what are the key challenges? I'm glad that some have already been mentioned. And that is why I said that more or less this is an overview. Some have been mentioned, but we can never have enough of it. It simply reinforces the idea that yes, there are challenges. And when there are challenges, there must be solutions. And so what are the key challenges? One of such is limited broadband coverage. We all know how unreliable our data connectivity can be. And we know that there's no way telemedicine can be properly put in place when we have unstable internet for video consultations, data sharing, and access to online records. When there is poor connectivity, it limits the reach and effectiveness of consultation. What is another major challenge? It's having to do with inconsistent
power supply. We all know, I'm glad when Dr. Belgori was speaking and she made mention of, solar-powered, devices. And so, as far as the country is concerned today, the government is trying, but you and I know that power is still a challenge in the country. And so when there are frequent power outages in healthcare facilities, it makes it really difficult to use digital devices, to maintain servers, or to conduct virtual consultations consistently. Another challenge is that of fragmented solutions. We have different hospitals, both at the federal and state, that are using uncoordinated telemedicine platform. And so when it comes to, having communication seamlessly, it is difficult. And so this creates data silos and makes it difficult to track patients across systems or scale innovations nationally. What about payment of services? We know that as it stands today in the country, a lot, when it comes to payment, it is largely out of pocket. And so there is currently no consistent model for paying telemedicine providers or reimbursing patients. Many teleconsultations are done out of pocket, which limits access, especially for low-income populations. There is yet another one, and that is variable provider readiness. We have a number of, our staff that are not trained. They are not digitally literate, and so they are not well equipped to deliver telemedicine effectively. And so it is not just enough to have the gadgets in place, but people also must be trained for them to be able to deliver, appropriately. During the panel discussion, someone made mention of regulation. That also is a problem, So as I begin to round up, I said that there are challenges and definitely there must be solutions. And so, what are the things that we need to put in place for us to have, to get to where we are going? One is to expand broadband infrastructure through collaboration with the Ministry of Communication, Digital Economy, and NITDA. We also have to encourage private telecom companies to invest in rural internet expansion through incentives such as tax relief or PPP. We have to deploy alternative energy solutions like solar power or hybrid systems in health facilities. We also have to integrate telemedicine equipment into battery backup systems. We have to develop a national telemedicine guideline and interoperability frameworks that ensure systems that can share data securely. We also have to promote standardized software and data exchange protocols. We have to collaborate with NHIA to include telemedicine in insurance benefit packages. We have to establish clear reimbursement models and billing codes for virtual consultations. Remember, I made mention of inadequate training, and so capacity building on digital literacy program among health workers is a must. We also have to integrate telemedicine training modules into medical and nursing curricula, as well as provide technical support and incentive for early adopters of telemedicine. And so when we are ready to embrace all of this, we will surely make visible progress. And so in conclusion, Nigeria's telemedicine ecosystem is advancing steadily and is expected to move from isolated pilots to coordinated national action. Our goal as Federal Ministry of Health is to make quality healthcare accessible to the 250 million Nigerians regardless of distance.
I believe that with continued collaboration among government, clinicians, innovators, and partners here today, that goal can certainly be reached. Thank you very much for listening. Thank you.
Thank you very much. From the Federal Ministry of Health, we especially and sincerely appreciate you. We will now take a few more presentations. I've been directed to humbly appeal to everyone to see how we can hang around 2 to 3 minutes for our presentation so we can progress quickly. First, I'd like to invite from CEDA, I'm sure the media team is set now. Yeah. After CEDA, we will take Village Reach, and then we'll now take AFC.
Thank you very much. I'm Leke Jegede from Solina Center for International Development and Research. I have the uneasy task of presenting a 2-year-long work in 3 to 5 minutes, and we'll try to do that very quickly. Can I have the slides projected? So this is a report from the Implementation Research conducted in Lagos in collaboration with the Lagos State Health Management Agency, LASHMA, funded by the Gates Foundation. And this writes on all the conversations we've been having today around, telehealth is not new. Telehealth can reach access and enhance universal health coverage. So this particular use case is about how to enable telehealth to adapt current telehealth solutions to reach the most vulnerable, underserved population in Lagos State. Yeah, next page, please. Next again. All right, so we are aware, the Lagos State has some of the best health outcome indices in the country. Yes, there are pockets of poor outcomes here and there. And we did a very quick assessment, identified 64 wards where there are population that do not have any health facility within 5-kilometer radius of them. This population also have not enough health workers in terms of the proportion compared to urban areas, and also has people with that are classified low-income earners. And we see that the health outcomes in this area are far worse than the national average. This work writes on the telemedicine solution that the Lagos State government deployed during the COVID-19 outbreak, EcoTelemed. And then this is to see how it can be broadened to indeed expand coverage. So we did rapid assessment. Next page, please. Rapid assessment to identify the needs of the target population. We also did an assessment to understand the models of the current telehealth service providers in Lagos. And we found from the telehealth service providers, they mostly reach individuals that already go to the PHCs, to the brick and mortar facilities. So the task is, how do we adapt what they're already doing to reach those that do not already go to any facility anyway, and see, can this truly reach access to healthcare? Next page, please. This is just to put some of my words in pictures to see what we tested. So there's the hotline, there's the market kiosk, and then there's the community pharmacy kiosk, which were determined from research as well as places where our target population visits from time to time. Next page, please. So this is where I'll spend the bulk of my time. This is the results. So we were able to reach 2.9 million people just to help them understand what telehealth is about. And this is coming from a baseline of 1% awareness, among the underserved population that we had reached about whether or not they know about telehealth. So we reached them, sensitized them, and some of them got to use the telehealth solutions. We also classified the mechanisms or the medium by which people heard about telehealth, got convinced and used the telehealth solution. So the community outreach is one that yielded the biggest results, whereby we had community-based engagement officers going to the communities. We also had people that just saw the kiosk walked into the kiosk and utilized it, and then referrals from friends and family as well. In terms of profile of users, there were over 11,000 interactions by the underserved population, and this cuts across 7,000 users. And we also see the different models that they preferred.
I think during the panel session, the CEDA board, Dr. Amina mentioned that the population that we sought to reach preferred a physical location, so it shows there as well. When we see the CP kiosk there, used by 3,774 individuals, market kiosk by 2,684, and the hotline only by 545 individuals. We also saw that the market kiosk was very effective at reaching the female population. This is also because the market kiosks were strategically selected to be one that is female dominated. We had Balogun markets where there were folks that sell fabrics and stuff, as opposed to taking it to an electronics market where you would have more men. CP kiosk, we can see the distribution between male and female is about uniform. Of course, more female still. What's very striking for us is of the exit survey that was done, there was 30% of the individuals that mentioned they wouldn't have done anything. They wouldn't have sought any care if the telehealth solution was not available to them. Of course, we also had other people that said if it wasn't available, they would have gone to a pharmacy, they would have gone to a PHC, they would have gone to TBAs, they would have just used any medicine that comes their way. But we saw 30% that wouldn't have done anything. And we think this is very powerful as a tool for bridging access to care. The kind of services they sought also cuts across chronic disease management, checking BP, checking blood sugar and stuff. Malaria as well, general care such as diet, sexual and reproductive care, and body pain. We did an elaborate willingness to pay, ability to pay analysis, which we are over summarizing here. 84% of the respondents are willing to pay 1,000 naira roughly per month to use telehealth solution. This is disaggregated, also with some recommendations for the different models. Then in terms of at the bottom left corner, the perceived value of telehealth, 97% perceive it as having equal or higher quality of care as they would have gotten from the PHCs. They also perceive it to be more convenient, 86%, to be cost effective as well, with short or no waiting time by 90%. We also checked privacy as well. Interestingly, not a lot of the respondents felt that it offered them privacy. We think that maybe this is because of the target population that we saw. Privacy was not top of their list, but I think we had about 12% that felt like it offered them some privacy. In terms of the different resources or enablers that are required, there are 5 of them that we identified as top enablers. That's the infrastructure. Understanding that a lot of people prefer physical kiosks, there's a need for a physical setup, digital tools, devices, monitors and stuff, software as well, the EMR solution. And one thing that we're also pondering and engaging on actively these days is how can we leverage existing infrastructure, such as PHCs that are underutilized, some even abandoned, to make something out of the sunk cost already. There's demand generation as well, which is very important. Understanding we're coming from 1% awareness of telehealth solution among the target population. When I say target population, I don't mean everybody in Lagos, but within the 64 wards where we have the low-income earners, where we have the poor access and all of that. So there was only 1% awareness, and there will be need for that continuous engagement in rolling this out at scale. Tailored messaging as well. Service provision and continuity of care. There's a need to continually train human resource to provide these services, standard protocols and documentation, referral mechanisms. We didn't have the time to share those detailed results, but the care didn't end in those kiosks. Some were referred to labs, some were referred to PHCs, and there was follow-up to see that they actually did that. So the telemedicine or telehealth solution, we also identify it's never going to replace the PHCs or the brick and mortar facilities, but it can be a starting point, an entry point for new folks that wouldn't have gone to anywhere at all. And we also see it's a good pathway to, transition people into digital solutions. Because while they prefer a physical location, as they interact, they then begin to engage remotely by calling and doing other things. I'm out of time, I am aware, and we'll just move very quickly to the the key learning page. General, sorry now. Yeah, so we identified a few things. No, next page, please. Yeah, community engagement is very important. The physical models work, the health information and assessment, and just the kind of services that people seek. Telemedicine will not, or telehealth stores will not deliver the full suite of services. So we need to be aware of that, and then some of the things that are important to people. I think I should stop now and say thank you very much for your time. Happy to engage and share more in as time permits. Thank you.
For the next presentation, I'd like to invite Madam Oluroti Doherty, especially for the next presentation. Please can we put our hands together for her? The African Export-Import Bank, that's Afrexim, and Afrexim Bank is our headline sponsor for this particular Nigerian Telehealth Conference 2025. And so we are going to appreciate her both in her capacity as Managing Director of Export Development Division and as a headline sponsor of this conference. Please, can she hear the clap? So she's not smiling because she's not hearing the clap. That clap should be a little louder until Mrs. Doherty is smiling. Please, can we put our hands together to appreciate our President Bank and to appreciate her as a person. Thank you.
Colleagues and partners, permit me to stand on existing protocols observed. It gives me great pleasure to share this good at the Nigerian Telehealth Confrence 2025, since scaling telehealth for universities in Nigeria, the pathway to sustainability. I would have loved to be with you physically in Abuja for this important dialogue today, because the subject of health and particularly equitable access to healthcare is one that I'm passionate about. However, I bring to you esteemed greetings from the management of Afrexim Bank and goodwill of everyone here at the bank's headquarters in Cairo, Egypt. We believe that this dialogue will not be more timely because across Africa, an estimated 600 million people lack access to essential health care, and more than 40% of Nigerians live in areas underserved by qualified medical professionals. Yet, technology now offers a powerful means to bridge that gap and to accelerate universal health coverage. As Afrexim Bank as both a human right and a pillar of economic transformation, a healthy population, enabler of universal health coverage. Yes. It complements physical infrastructure while building new skills and new jobs and new opportunities within Africa's emerging health economy. We are proud of our partnership with Mobile Health International, and we believe that it exemplifies this conviction. In Nigeria, telehealth will complement some of our flagship initiatives, like the African Medical Center of Excellence in Abuja, which is a 350-bed facility that delivers world-class tertiary health care to Nigerians and West Africans. While AMC Abuja provides advanced diagnostics, oncology, cardiology, and maternal child health services, Telemed that expertise beyond hospital walls. It will create a continuum of care that will link communities, primary health centers, to specialist healthcare centers like PMC across Nigeria and across West Africa. Through blended finance instruments like our guarantee products, our technical assistance support, our project preparation facility, Afrexim Bank continues to invest in projects that strengthen health systems, from digital platforms to medical manufacturing to pharmaceutical production. We therefore commend Mobile Health International, the Federal Ministry of Health, and all partners here today, including the USTDA, the Gates Foundation, for leading this digital health revolution. As this conference contributes to the National Telehealth Sustainability Framework, which will be presented at the National Council on Health in 2025, Afrexim Bank reaffirms its commitment to financing innovations that bring quality care within the reach of every African. I enjoin all of you to do this conference not just as another event, but as a defining moment for Nigeria's digital health future and a potential model for the continent. Your participation, your collaboration, and your collective will are what will turn ambition into achievements. Together, let us build a healthier and more connected and self-reliant Africa, where technology and innovation make universal health coverage not an aspiration, but a reality in our lifetime. I thank you all and wish us all fruitful celebrations at this event. Thank you.
One more time for Afrexim Bank. Please can we clap the 10 times louder? So we take our next presentations. We have about 3 sets now to take. Medicaid, Village Reach, and AFC. And CEO is here. But we'll start with Village Reach. He has assured me he will reach within my time. Mr. Tapo Awubeko. Please can we put our hands together for Mr. Tapo?
Hi everyone, good afternoon. All protocols duly observed. I have an impossible task. I would start, I would not finish, but I'm dressed in green, so please look at me well and let's talk. So my name is Tapo, I work with Village Reach, and I want to discuss something we started about last year called the Global Telehealth Community of Practice. I'll make a case for why we should have one in Nigeria as well too. So the slides please. Next slide. So the challenge is that we've seen that many countries do not have national scale strategies that we can leverage to reach underserved communities. That's the challenge. We also do not have that coordinated and collaborative focus at both the global and country levels to sort of drive activity around the regulation, quality assurance, and integration to health system and long-term sustainability. And what we thought to do is create a platform that brings everyone together, everyone doing work in telehealth, where we can share knowledge, access resources together, and collaborate to sort of strengthen the ecosystem. Next slide. So our vision is to ensure that every country has a sustainable integrated telehealth service that allows people access to timely health information, connecting to health services, and provides government with data needed to ensure and just really improve healthcare systems. Next slide. So the GTCOP is formed by a couple of partners. There's Village Reach where I work, and we all form the steering committee of the call group. We also have Geneva Big Child Hub based in Geneva, and we have the International Society for Telemedicine and e-health as well. Then we have WHO that forms as members of the steering meeting that sort of guide what happens at the GTCOP and meet every Thursday to determine all of this. Now the GTCOP is designed to fit squarely with WHO's GIDH initiative, and particularly the fourth one on convening and knowledge exchange. Next slide, please. So we have a few objectives, but in summary, the goal is to create that community of practice that strengthens each country's efforts to not just have telehealth instituted or used effectively, but ensure that we can work together, policymakers, academia, private sector guys, NGOs, and everyone to really just strengthen what is being done in each country on telehealth. We've done this in 2 countries, Malawi and Tanzania now, which the next slide will show you. And we think with where Nigeria is and what we are beginning to do, it makes sense to have this as well in the country. We have a few steps to setting up the COP, not very difficult. Identify stakeholders, co-create that goal and objective from the COP that we want as a country. Next slide will show you that. Map what we should achieve within a year or 2, and we just kick things off. Again, summary is that we think if we would scale telehealth in Nigeria and any other country, we need to work together. We cannot work in silos and get things done. So academia, policymakers, government, private sector, whoever it is that does work in telehealth, there needs to be that forum where we can sit together and have difficult conversations where necessary, and also support the country in achieving its policy goals with telehealth. So I work with Village Reach, and if this is something you think you want to get involved in, we speak to WHO or the ministry as well, we should have that conversation, and we would very much look forward to starting this in Nigeria with all partners involved. Thank you.
Distinguished guests, ladies and gentlemen, especially appreciate Village Reach for that quick and straight one. Coming up next, distinguished ladies and gentlemen, is Brian Diva. He's the Chief Executive Officer of African Medical Center for Excellence, AMC. He has served as a level of senior leadership experience in the healthcare industry for over 29 years. With his extensive experience in healthcare strategy, operations, and financial management, Mr. Diva is leading AMC's mission to establish a world-class medical institution that will redefine healthcare excellence in the region. Distinguished guests, ladies and gentlemen, I'd like to invite for the next presentation the Chief Executive Officer of the African Medical Center for Excellence, Mr. Brian Diva. Please can we put our hands together for Mr. Brian? We will quickly take our second panel discussion. After that, we'll go for lunch. But right before the panel discussion, I'd like to specially invite for the final presentation, this time around from Medic 8th Cancer Foundation, I'd like to invite Mr. Ibanga Richard.
Good afternoon, distinguished guests, esteemed and respected leaders present, members of the medical community, ladies and gentlemen. It's with great gratitude and pride that I welcome you to this presentation on the most innovative cancer emerging technology hub, Medicaid Cancer Foundation Tele-Oncology Experience. For over 11 years, the Medicaid Cancer Foundation has been at the forefront of the fight against cancer in Africa. From the very beginning, our mission has been very clear and unwavering: to remove barriers to quality cancer care, to navigate patients through their journey and empathy, and to advocate for systems that prioritize people and not just the disease. Our work in patient navigation, advocacy, and early detection has changed the narrative of what cancer care can look like, especially in environments where limited resources often dictate outcomes. We have built partnership across borders in Nigeria, Ghana, Kenya, and beyond, establishing a Pan-African network that strengthens regional capacity and collaborations. Yet, for all our progress, the truth remains. Cancer care in Africa still faces profound inequalities. Across Nigeria and most of sub-Saharan Africa, the shortage of oncology specialists is staggering for a country of over 200 million people. This shortage translates into long waiting times, delayed diagnosis, and treatment plans that often come too late. Patients from rural communities travel hundreds of kilometers from places like Mina or Lokoja to reach Abuja or Lagos just to see a specialist. Many sell their belongings to fund this journey, some actually never make it. It's become clear that the model of care had to evolve, that if patients could not reach the specialist must find a way to reach patients. The birth of the tele-oncology solution came out of the realization for an innovative digital oncology platform developed in partnership with Mobi Health International. This initiative represents a bold new frontier using technology to democratize access to oncology expertise. The model is simple yet powerful. It connects patients and doctors in distant locations with oncology specialists through secure video consultation, electronic record sharing, and coordinated follow-ups. Patients can now access expert review and guidance without leaving their communities. Next slide. So, ladies and gentlemen, tele-oncology is far more than a technological achievement. It represents a moral commitment to fairness, access, and compassion. It bridges the gap from scarcity to access, from delay to timely action, and from distance to dignity in care. In the words of our founder, Innovation in healthcare must never lose its heart. Tele-oncology embodies that spirit. Technology through this model, we are proving that African solution can address African challenges. So together, let's create a future where every African can receive world-class cancer care when and where they need it the most. Thank you.
Thank you very much. So we'll take our second panel and then we'll go for lunch. Okay, I'd like to invite the members of the panel for this second panel discussion, our panelists. Let me invite, first of all, the DG of NHIA. If they are physically here or ably represented, we have them on the panel, Dr. Kelechi Ogiri. I'd like to also invite ED and PHCDA, Dr. Muni Aino. Then we also invite, representing Afreximbank on the panel, I'd like to invite Dr. Salamatu Belgore. Let me also respectfully invite the CEO of Bisham, Mrs. Tinu Akibolewa. Please, sorry, can be on stage. And of course, I'd like to also invite, representing HFN, Ronald, to also be on stage. Reverend Ronald. Dr. John Adesioye is supposed to also be on the panel. Yes, CEO of Utopia Consulting. I got that. Thank you very much, sir. And of course, Roland should also be there representing HFN. I'd like to invite our moderator, distinguished guests, ladies and gentlemen, the CEO of ABC Health. Help me invite Dr. Maurice Atoki. Please, can we clap for our moderator? This particular clap should be loud.
Distinguished ladies and gentlemen, and Master of Ceremony, good afternoon. Is it afternoon yet? Yes? No? Good afternoon. Okay. Good afternoon. I promise to make it as fast as possible. But while we welcome the distinguished panelists, it gives me a lot of pleasure to be here today, to really appreciate the organizers, and particularly Dr. Fumi Adewara for the audacity that she displayed to convene all of us and this conference. We must agree that it's taken a lot of energy, grit, and persistence. So please join me in applauding Dr. Fumi Adewara, the Chief Executive Officer of Mobile Health. Today, at this second panel, we're going to talk about another interesting topic. So if you were the first panel, I was here, and I really appreciated all of the viewpoints and the learnings, that were exchanged in the first panel. We heard about the usefulness of the guidelines, but also we've been encouraged to be more audacious and have appetite for policy and a regulatory landscape to be able to drive this forward. And that's a charge that I want to bring as we go into this second panel on financing, on partnerships and sustainability. And our topic is innovating financing and partnership for sustainable telehealth integration. This session represents a pivotal step in Nigeria's ongoing efforts to finalize and operationalize the Nigerian telemedicine guidelines, an instrument that not only defines our digital health aspirations, but also determines whether those aspirations can actually be sustained and put into practice. Across the world, we would agree that in digital health and telemedicine, there's a rapid transformation care delivery ongoing, extending access, optimizing efficiency, and enabling new models of health financing. Yet, when we talk about Nigeria, the success of telehealth will hinge on how all of us, together today and beyond, will design sustainable financing structures. We'll think about it and interact with them, enabling investment readiness and institutionalizing partnerships that transcend project cycles and donor dependence. Today's conversation, therefore, will seek to address 6 interlocking priorities central to making telehealth a durable component of our health system. Number 1, we must tackle the issue of mainstreaming telehealth financing, ensuring that digital consultations, diagnostics, and remote monitoring are not treated as optional innovations, but as reimbursable services under the National Health Insurance Authority, the Basic Healthcare Provision Fund, and the State Health Insurance Schemes. Secondly, we must examine public-private partnership models intentionally, ones that can balance innovation with inclusivity. The private sector holds much of the capacity and technology needed for scale, but sustainable public-private partnership must be structured around clear governance, risk-sharing, and accountability frameworks that align commercial incentives with public health goals. Thirdly, there is a question of funding mechanisms and blended finance. We must aspire to address how we can creatively combine donor, government, and private sector capital to expand digital health infrastructure. Number 4, we need to enhance digital health investment readiness. Nigeria's health sector has significant potential, but to attract sustained financing from development, financial institutions, venture funds, and impact investors, our policy environment must be clear, must be predictable, and must be performance-oriented. We must also embed accountability and transparency mechanisms to ensure that financing translates into real health outcomes. And finally, sustainability and local ownership must remain at the center of every financing model. Again, I reiterate, the conversation you're about to hear at this second panel brings together key actors, deliberately put together from across financing, policy, and implementation spectrum. Please join me in applauding the carefully selected panelists as we start our second session. You will not go for lunch if you don't clap, because you are not looking like you want to clap. Thank you so much. Right, I'm going to start with Dr. Muya now. So please tell us, how can NPHCDA integrate telehealth financing into PHC revitalization agenda under the Basic Care Provision Fund? And you can tell that this question is deliberate. We know the recent functionality of the BHCPF and also the necessity as we're reinventing and refurbishing public health centers, primary health care centers. It's also a great opportunity for NPHCDA to consider integrating telemedicine. Please tell us a bit about that.
Good afternoon, my co-panelists, the moderator, ladies and gentlemen. To respond to the question that was asked, I want to first of all state that while telehealth reimbursement mechanisms is currently not operational in NPHCDA, but we as working toward the sector-wide approach, we are working collaboratively with the Federal Ministry of Health, the National Health Insurance Scheme. We are also working with development partners to ensure that resources are pulled together to work towards achieving some of the fundamental infrastructures as far as telemedicine is concerned. Currently, we are not, it's not operational, just like I said at first, but we are laying some foundations that will enable telemedicine to become a reality in no distant time from now. And as far as funding is concerned, we're not using any separate mechanism, but we're just leveraging on this sector-wide approach, which emphasizes that funds are pulled together to ensure that needs of the government are met. Not partners doing things the way they used to do, but all resources that are meant for health are pulled together to achieve a common goal.
Thank you very much, sir. I'm glad that, there's already thinking around it, even though not operational yet. It's imperative that we take from here today the necessity that it's also integrated, like every other necessary framework building that needs to happen while we consider the BHCFPF fund and also the reforms going on at the primary healthcare. I'd now like to go to Dr. Salamatu Delgado, Director of FCT Health Insurance Agency. You're very welcome. Thank you for joining us. Please share with us what lessons the FCTHIA's pilot programs can guide other states in financing telehealth through subnational health insurance schemes.
Good afternoon, everyone. The moderator and co-panelists, permit me to stand or align with the already established protocol. The FCT Health Insurance Scheme is a subsidiary of the Health Services and Environment Secretariat under the FCT administration, and we are the state counterpart of the social health insurance scheme in the country. Every state in the country has a social health insurance scheme, including FCT, and then NHIA is our regulator, just to give a background. So we all know that as part of the 3 dimensions of universal health coverage, one of the key dimensions is service delivery. And for us to have equitable access to quality services, especially for the vulnerable persons, there needs to be, we need to bridge the gap in, especially human resource, where we all know that, especially at the new training and the hard-to-reach areas, we have serious gap in regards to human resource for health. So what we have done at the FCT, Social Health Insurance Scheme, precisely, is that we have actually, begun a pilot of telehealth consultation to vulnerable persons in some very remote primary healthcare centers in the FCT. My mandate secretary particularly mentioned that when she was speaking earlier on, and what we did was, okay, we have a total of 62 political wards in the FCT, and for each ward there is a basic healthcare provision fund primary healthcare center that is accredited to provide services to the vulnerable persons. But I must say at this point that compared to a population of over 7 million in the FCT, 62 PSCs is grossly inadequate in terms of geographical, physical access, and even financial access. So with the support of the mandate secretary, we were able to conduct an accreditation visit earlier in the year to 100 PSC facilities, and successfully we were able to get 54 new PSCs on board through the NHIA, which very recently were just communicated on that. So enrollment is actually ongoing in those new facilities, and now we're leveraging telehealth to ensure that we bridge the human resource gap in those facilities. So what have we done? We actually did like the triaging and did a situation analysis, try to get which facilities do not have the adequate, the complementary strength of human resource where telehealth can come in and bridge the gap. So we enrolled vulnerable persons, we got philanthropy support, and we enrolled vulnerable persons, a total of 833 into these PACs. And we have telehealth booths stationed at those PACs providing services to these vulnerable persons. And because we actually did a lot of community engagement, so the community members are aware, and they're actually excited about the services they are getting. Even the staff, the healthcare workers at the PSCs, it's a form of relief for them, because now we have doctors through the telehealth platform, through Mobile Health, interfacing with these patients real time. And we did actually an actuarial analysis whereby we try to integrate it into health insurance. So part of the capitation component for consultation is actually what we now use to pay off for consultation for telehealth. We also have, to cap it up, we have referral linkages with nearby secondary healthcare facilities with whom we pay fee for service on fee for service basis to provide specialized care and cesarean section and all whatnot to those pregnant women as the need arise. So lessons learned or sustainability, because this program is like a pilot, it's going on already and it's going to be for 1 year. So lessons learned is especially with regards to sustainability. We all know that even at the moment, out-of-pocket expenditure for health is still very high in the country. Health insurance coverage is still suboptimal, though the state health insurance scheme and the NHIA is trying so much in terms of population coverage. But when we look at population coverage, it's just one of the dimensions of universal health coverage. We also need to look into service delivery and the financial protection aspects. So I would still want to urge the Federal Ministry of Health, the NHIA, to look into how we can, integrate telehealth into health insurance. Probably through what we are piloting now. You can come and understudy what we're doing, and then we can have a scale up of what we're doing presently across the country, and then that will help to, enhance sustainability and, access for this group of persons that, are really vulnerable and need those services the most. Thank you.
Thank you so much, Dr. Salamati. I hope you heard her, because she's softly spoken. She's landed a lot of heavy words. The question was, how do we see other subnationals replicating what's been done in the FCT? I mean, these are the people who go on the field. So in actual fact, these are the people who interact with the community. It's been tested. And so please join me once again applauding the work that has gone on at the pilot level at the FCT in telling us and making us see that this can really work in this part of the world. So thank you so much. Thank you once again for those remarkable comments. I'm about to come to Dr. Adesio, Dr. John Adesio. And I'd like for you to reflect a little, and I know that you're from the diaspora, on some of the things you've seen better done in more advanced environments, and how you want to what are your expectations for Nigeria as we're evolving at this stage of moving with telemedicine and ensuring that perhaps it's one of the most critical ways we can actually achieve the UHC. What do you see that is still being undone or that we should do more of and less of as a nation? Over to you, sir.
Thank you, Dr. Morris, and good afternoon, everyone. When it comes to what we can do more right now, or what we can do differently, I think we're working along the right path. A few years ago, even though telemedicine is widely available in America, a lot of people didn't know about it till COVID hit. Around here, virtually nobody knew around it till COVID hit. But the difference is now people think telemedicine has gone away because COVID has gone away, and that is not the case. One of the reasons why telehealth is very important, telemedicine, is because we have a shortage of healthcare professionals. And we're not just talking doctors, we're talking nurses, we're talking physiotherapists, we're talking across the board. What technology gives us an opportunity to do is leverage what we have to actually be able to get the most of what we don't have. For instance, we currently have a platform, we have a remote patient monitoring platform that we've deployed in cross-river states, in local government areas that has no obstetrician. And we have healthcare workers that we've trained to use an app to go into these primary care centers. They don't have maternity centers. They go into primary care centers. They can take questions from these mothers. They put them on the app, and a consultant obstetrician in Calabar gets a dashboard, green, amber, red, that says, okay, this patient is fine, this patient is okay, this patient has a problem. This was a pilot program, which, as we say, pilot programs don't really become beneficial except it becomes something that can actually be scaled and be actually beneficial to most people. And with this program, only 40 women that we started with, 100 delivered. One thing we've realized is no one has missed an antenatal visit. every possible complication has been cut to them. So early interventions have happened. Okay, so these are the things that happens in what we call the West, that people go into every antenatal care that we don't tend to do here for numerous reasons. One, cost. How much is it going to cost? I can go to my healthcare center. Two, if I'm going there, who do I see anyway? There's no obstetrician there, so why am I going? And some people leverage traditional birth attendants, which is not necessarily a bad thing. But what this gave us an opportunity to do was actually to teach, train, build capacity. So the healthcare workers actually know what question to ask these pregnant women that ordinarily they may actually not be aware of. And they're asking us questions. So what if this happens? What do we do? It's simple. What does this mean? So we're teaching, we're training. So telehealth doesn't just mean we actually give care to those that need care. It means we can actually expand a whole lot of services that we may actually not think of, including training people in the rural areas. One of the things that we don't have the good advantage of is widespread good technology. You go into certain places you don't have network coverage, which we have in places like America and the UK. But mobile health, for instance, are deploying, solar-based, technology in places where you don't have good access to electricity. So we're leapfrogging things that have been done in other places locally, because we now know that these things are things that we can actually leverage locally, and we're bringing them to our environment to see how we can use it to actually scale up what we do and lead us towards universal health coverage. Some things have been touched on that are very, very important, like the NHI, saying that we actually have to be able to have clear reimbursement framework to say certain things can be reimbursed for and certain things cannot. And to what extent do you reimburse for them? And the NHI can say, okay, if you have an insurance platform, you have to actually provide telehealth services. Let people pay for it. That way people know that because they can't go into hospital doesn't mean they can't get care, even though they have insurance. And another thing that you can actually do is when they actually talk about insurance coverage, they talk about the fact that yes, you can get telemedicine and actually promote it. Because if you don't know it exists, how do you ask for it? How do you leverage it? We talk about PPPs, which is very, very important. A lot of people can actually develop infrastructure that can actually help deploy some of these, technology that we use for PPPs. But when you have a clear, defined, long-term goal, so okay, we're bringing a private partner in to say, okay, help us deploy this technology, but we're not going to kick you out after 4 years when this particular governor leaves. But we have a 30-year program where you can take your time to get your gains from whatever program you're installing in place. So the private partner knows that, okay, I'm not going in there and be out in 2 years. I have 15 years, 10 years, 30 years to work to actually recoup my gains. They're more actually inclined to go into rural areas where they know they can't charge as much as they can do in the urban areas for their services, and deploy this technology that we know is needed in every single part of the country. And part of this includes, including performance-based payments for some of this technology that the private sector is bringing on board. So the fact that you're putting it there doesn't mean you're just going to collect your money. Patients have to be satisfied. There has to be ways to actually, leverage what outcomes we're getting from it. And they say data is like oil now. You go to all these places, you deploy this technology, you get data back. That's actually going to be important in how we actually, strengthen our healthcare system going forward.
Thank you so much. A lot to learn for. Please feel free to applaud him. I hear you quite clearly. What I've heard fundamentally is that we should leverage what we have. And I think over that you built on some of the things you've observed. What can we do better? I hear you clearly about the NHI is overemphasized. On the first panel it was spoken about is simulating NHI and insurance within the telemedicine solutions. We probably will not move forward if we don't crack that particular nut. So we thank you for those remarkable comments as well. Now I'll go to my friend, Dr. Ronald Reagan.
joining us from the Health Federation of Nigeria, and perfectly representing Dr. D.A.G.D. Indeed. Can you share with us, and having been part of the private sector healthcare providers and professionals, what would you call financial incentives that will attract private capital and foster investments in telemedicine here in Nigeria? Over to you, sir.
Thank you, Dr. Morris, and good afternoon, everyone. My name is Reagan Roland. So, to attract investment, we must take a look at investments first of all, right? Telehealth. Telehealth is, like we've heard over and over again, is not new. But you want somebody to bring money in, what do you have to show to the person that you're ready to receive this money or this investment? So first of all, we must clearly start from clear investments in our own telehealth enablers. Talk about the GSM coverages, power, like they said in the sessions today, and the solar power powered approach that mobile health is taking, for example. We need these things to show proper traction for private investment, for them to know that we are actually ready for more money to come in. It's kind of like this saying, when you want to go asking somebody for something, you need to show to them that you have yourself, right? And that's where that comes in. There's also a need for a mix of clear regulatory interventions. Telehealth, for example, the regulations need to be very clear so that investors for a fact, this is what it is and this is what the outcome will be. And I believe that's part of what this guideline will also feed into. We need to have de-risking mechanisms for these investors when they bring in their money. And we also need to have targeted incentives, which will help their investments, will help them to even come back after maybe initial investment, will help them to, in a way, look at other investment. An investor can come in for one particular sector and see another thing that will complement that same sector and still decide to invest, right? This is what tax incentives can do. So in order for us to optionalize the NTG, I think one of the first things we must do is have a very clear licensing framework so that people know for a fact that this is what you need to do if you must become a telehealth consultant or an organization. There are lots of telehealth providers out there, to be honest, and a lot of them unregulated, right? And you can't actually blame them because they probably researched and checked and couldn't find, and then they are probably modeling after one thing they read online or one research they did online. Two, we must also have interoperability standards. I know that has not been mentioned, but it's never enough to re-echo it. So you use mobile health today, you decide that you want to use another telehealth tomorrow. What happens, right? This framework should clearly define how it can be interoperable as well. And of course, lastly, is streamline approval pathways for digital health platforms. So with all of these things in place, investment into the sector will be much easier.
Absolutely. Please join me in applauding him. We've spoken to what we consider the needs of the private sector and what is necessary to attract private capital. We're talking a lot about telemedicine here. What will it take an investor to prefer investing in telemedicine as against oil and gas? So we need to do more. We need to think critically about it because this is where the decisions are being made. Like I said earlier, this set of panelists were carefully selected. I'm going to give them a round for their closing remarks again because you have to go for lunch. Please clap for me for doing that. If you don't clap, you won't So they're going to try and address all of the questions, but in their closing, and to give them an opportunity so that we can learn from them, from their very wide range of experience on this topic. So I'd like to start with the representative of the MPHCDA, Mr. Mui, I know. Over to you.
Thank you so much, moderator, and thank you everyone for giving us the opportunity to be able to air our experience in the area of telehealth. I strongly believe that if we put everything that has been said here today into practice, and we're really serious. We are able to put in place policies that enable some platforms to be made available. We'll be able to attract a fund that is needed to drive telehealth in Nigeria and have an environment to improve our healthcare. Thank you so much.
Absolutely. Dr. Roland.
We are already there. We want telehealth to scale. If we really want telehealth to scale, we must embed it, nationally into everything that we do in financing, for example. A good way would be to adopt what you said, ma'am, about having telehealth embedded within micro-insurance schemes. So when you are buying an insurance, you know that part of the things you must receive, whether you go to a hospital or not, is the opportunity to have telehealth consultations wherever you are, because you're already paying for it. So embedding that would really work, and I believe all of the other contributions, will help us to scale telehealth greatly. Thank you.
Thank you very much, Dr. Roland. I do recall that Dr. Ann, representing Dr. Chinola Kimbalagi, the CEO of PSHAN, was supposed to join us virtually. Please, can we have her so she can give us our own contributions? Right, Dr. Ann, can you hear us? Perfect. So sorry, we didn't miss you. It was lunch, They are trying to rush me because of lunch. So please tell us, in a very timely manner, how do you see private sector better being incentivized in investing in telehealth under the NTG? And while doing that, also please give us your closing as we're at the closing stage. Over to you, ma'am.
Thank you very much, Dr. Atoke, and it's a pleasure to be here this afternoon. So, if we must get private sector to continue to invest in telemedicine, there has to be a clear, succinct business case as to the value add of telemedicine as opposed to traditional practice. It's important that we have this business case that speaks clearly to value, that speaks clearly to efficiencies within the system, and speaks very clearly to the sustainability of the platforms that we choose, to deploy, in line with the new policies of the federal government in telehealth medicine. It's also important that we involve the private sector in the policy framework that provides an enabling environment for digital health to thrive. It's also important that we communicate very clearly the nexus where the handshake between the private sector and the public sector will be evident, and making sure that that case that we have made has capacity to speak to the nuances of the various communities in which we will be deploying telehealth. The way Nigeria is structured, it's not a one-size-fits-all, and therefore this business case must take into account the differences that we find in the several geopolitical zones across Nigeria. It's important that the people own the technology and that it resonates with them from the get-go. It's important that in involving the private sector, a bottom-up approach is required to ensure that everybody is a joint ownership for the process. That's the only way that it's going to work, in a way that year in, year out, the needed investment in deploying technology is available, makes any contribution, any meaningful contributions at all. So in closing, I'd like to say that involvement of deploying digital technology requires a whole of society approach. It also requires a clear role for the private sector to see where they can fit in to the landscape and ensure that they continue to support the deployment of technology. But that cannot be possible without the enabling environment as created by the government. Thanks, and over to you, Dr. Torres.
Absolutely. Thank you so much for those very remarkable insights, especially on behalf of the private sector. And because of your remarks, I'm going to call Dr. Adesiuri. I did hear you talk about the need for continuity in public-private investments, especially if we require the private sector to be part of it. So we talk about PPPs without thinking political. Sometimes some of these tenures are 4 years, maximum 8 years. And that is sometimes the life of these transactions. That's not sustainable for private sector. So in sharing your remarks, I'd like you to talk a bit more about those expectations. So it's loud and clear that what you hear is the government, they need to take it back in your closing, and then afterwards we'll hear from the gracious Dr. Salama to round of us. Dr. Adesiri, over to you, sir.
Thank you. I think it's important when we talk about public-private partnerships to understand that at times we have to leave government as an entity out of the public aspect of the public-private partnerships. The fact that we have a public-private partnership doesn't mean we have to go through the government infrastructure to do it. You go to a local public hospital and develop a relationship with them that you can actually make work. And that we've actually leveraged this in numerous instances. We have to be very creative in ways in which we finance some of these initiatives. Some of the things we've done is when we've realized that basically the savior of the healthcare industry has to be the private sector, because a lot of capacity lies in the private sector. Obviously, we can't do it without the enabling environment that the government provides. But we've now realized that you have to be local. You have to find donor-driven initiatives. We have people who say, I do business in this part of the country. How can I impact it? And we go in there, we do a gap analysis. What are the needs? What's the disease burden? What are the infrastructure gaps, both physical infrastructure and equipment? What are the operating deficiencies? What are the human capital gaps? And you come in with a private partnership, this is where you can play to actually make a difference. And a lot of private partners are actually willing to do that. Some are actually not healthcare focused at all, but find healthcare partners to say, help us in actually making a difference in the community. When you go into a community, when you're engaged with a local person who understands what the needs are and wants to make a difference, it's the gains are immeasurable. So in closing, I think it's important that we actually leverage, creative ways to actually finance some of these initiatives. Some of them include, leveraging the private sector and letting them actually prioritize local ownership and align to local needs, and basically partner with government, but knowing exactly what the limitations are and knowing how to build from them.
Thank you very much, sir. Dr. Salama, over to you.
Thank you very much once again. As a form of closing remark, I would want to first of all say that health insurance in Nigeria and even globally, but particularly in Nigeria from our own experiences, is enrollment for the informal sector is a very hard nut to crack. Why do I say this? You go out there and market health insurance to people, the group of Okada riders, the market women, and the question they throw back at you is, are you praying for me to fall ill? Why are you asking me to make contributions when I'm not ill? So they don't have the perceived need, to pay for health insurance until they are actually ill. So when you see people walk up to our health insurance scheme, or walk up to us that I want to enroll, it's probably because they are not seeing one element or the other. So when we're talking universal health coverage, and the perception also about people that some of us are already, we've enjoyed health insurance services. But one of the main issues is waiting time at the facility because of inadequate human resource, shortage of equipment and supplies in terms of drugs. So when we do client satisfaction surveys, those are some of the outcomes. And in bridging some of these issues, telehealth, telemedicine coming on board, being integrated into health insurance would actually go a long way to improve the perception, especially when it comes to client satisfaction and improvement in quality service delivery. At this point, I would like to appreciate the MD CEO, Mobi Health International. She's done a lot in terms of getting telehealth on board. and we have started to pilot it in the FCT. It's working. We're going to get documentaries out there very soon. The people in the nook and cranny who are, the major people in the informal sector in Nigeria, the people that are earning below or living below the poverty line that need the services the most are, enjoying the telehealth services and they are happy. So I would want to, encourage the federal government and the NHIA to see how we can embed this into our policy documents to make it more sustainable and in a holistic manner so that, telehealth will come to bridge the gap in quality service delivery and equitable access to health services for Nigerians as a whole and also to improve our healthcare indices in the country as a whole. Thank you very much.
Can we give a resounding applause for that closing and for what work Mobile Health is doing in this space? I did challenge us 2 years ago. I told very pioneer, act like one. And I'm glad that I'm seeing this. I'm deeply inspired. Dr. Fumi Adewara, you have earned this space. We congratulate you. And we congratulate the entire Mobile Health for doing this. Please, another applause for this set of panelists. They've done well, and they've done justice to the topic. Take your time, please.